you first to the organizers for the invitation. Very happy to be here. I'm going to, excuse me, pick one topic. So Ben gave this very nice overview. I'm going to pick one thing that he kind of mentioned towards the end. And I'm going to be talking about the supply side of this market. And in particular, the care delivery or hospitals is what I'm going to talk about. So I want to kind of just as an overview, convince you, hopefully at the end of this talk about two things. One is that, this is a very important topic. There's a significant share of the total healthcare cost that comes from hospital costs, and also huge impact on patient outcome and welfare. And then I want to kind of talk about, the main problem here when we look at hospitals, which is matching hospital resources with patients in need. And this is an area I think we haven't seen a lot of work from the market design perspective. And I think there's a lot of room, there's a huge opportunity for doing interesting, important work here. The reason that I think this is a particularly interesting area of research is because there are multiple parties involved here in the decision making, making these allocation decisions. And as a result, there are lots of competing objectives and incentives. And finally, one thing I want to highlight is the behavioral aspects of these allocation decisions that are made in hospitals, and in a lot of cases, human error. And I think this is very important to take into account when we think about improving the efficiency of allocation of resources. So first, just to kind of convince you that this is an important topic, over 30% of the total national health expenditure is hospital expenditure. Okay, so this is, in 2022, for example, this is more than $1.3 trillion a year. So huge size magnitude of impact here. Second, in terms of hospitals providing care to patients, we're thinking about this is the most urgent type of patients, the most severe conditioned patients. They receive care at hospitals. So also from the patient outcome perspective, and I'll show you some examples later, this is important topic. And finally, in the economics literature, there's a kind of limited work on this topic. So hospitals largely kind of remain a black box, and we know very little about, or we've looked at very little about, what's really going on inside hospitals. So the question that I want to talk about here is, are hospital resources allocated in an efficient way? Okay, of course, there are other aspects that are equally important, for example, fairness, it could be one important question here, but I'll focus on efficiency here. So some examples of allocating these resources to patients. So first, in intensive care unit, okay, or ICU beds. These are allocated to, of course, patients with the most urgent, highest severity. We care about them. They are, 15 to 40% of total hospital costs, so very large fraction. And in this country, most ICUs operate near full capacity, right? So very extremely scarce resource. So we care about, really allocating them in an efficient way. Operating rooms, so OR, how we allocate them to surgeons, of course, and surgeons also match with patients, okay? So this is also important question. ORs are, traditional revenue engine for hospitals. So they could count up to 60% of total hospital revenue. So we want to think about really allocating these resources in an efficient way. And if we think about, just regular inpatient units, so for hospitals in the US and a lot of other countries, these beds are organized by specialty. Okay, so for example, cardiology patient would be typically allocated a bed in a cardiology unit. But of course, when we have congestion, when the cardiology unit gets busy, a lot of times the patients are sent to what we call an off-service unit, okay? So it could be an orthopedics unit. So there's also matching between these specialty beds and patients of different specialty in the hospital, okay? And then, of course, there are other treatments and tests and prescriptions that happen inside the hospital, and we also care about the efficiency of allocation there. So in terms of the impact of inefficient allocation on patient, so first I want to kind of try to convince you that impact here is really huge. Okay, so studies have looked at, for example, access to an ICU bed could reduce readmission rate by 32% for the high severity class of patients coming from the emergency department. Okay, access to an ICU bed also reduces hospital length of stay. So this is a common measure of quality, a common measure of patient outcome that hospitals use. So an access to ICU bed could reduce hospital length of stay by more than 1 day, which is substantial. This is a large impact. If we think about OR scheduling inefficiency, so studies have looked at, for example, inefficiency that leads to heavy daily workload of a surgeon, and this could lead to up to 9% longer post-surgery length of stay for a patient in a hospital, and more than 20% longer ICU length of stay. Okay, so these are important impact on patient outcome. And also from the financial economic perspective for a hospital, these are large impact. There are also studies that look at off-service hospital admission and misallocation of other types of treatment, how they lead to poor patient outcomes. There's several recent papers that look at, have found evidence of that. So what is kind of the problem there, or how do we think about these allocation decisions that are being made inside hospitals? Why is this interesting area of research? First of all, there are multiple parties involved in making these decisions. Okay, so first we have physicians who are actually making decisions for their patients. You might think, well, why is this a challenging problem? Physicians should know best about their patients, so they should be making the right decision here. But if you look at the data, look in practice, this is very far from what we have in mind. So first, for physicians, each physician is responsible for their assigned patients only. Okay, so in some sense, physicians are kind of competing also for their patients for shared resources inside a hospital. And so then there's incentive issues here already. And for some physicians, they might also have their own practice, right? So Ben had also mentioned, how physicians get paid also plays a very important role. So there are financial incentives that physicians are facing that we need to take that into account when we think about these allocation decisions as well. And third, and this is also something that I really want to highlight, is the behavioral factors. Okay, so this is something that probably will not realize until you start looking at in the data. So peer effect, for example, so physicians sometimes make team decisions, for example, this could have an impact on how they make their allocation decisions, naive decision making, and in a lot of cases, even physician error. Okay, so I'll show you some example of this in a little bit. When you talk to hospital managers, they also acknowledge their physicians make errors, although they are highly trained professionals. A lot of them will say probability of a human error here, even for they're very good physicians, are probably up to 60 to 70%. Okay. And then of course there's also hospitals. Okay, so hospitals also play a very important role here. For the outcome of the allocation. So hospitals might prioritize certain types of patients right? So for example, when we think about ICU beds, there's both surgical patients and medical patients, and the hospital here would set the rule or provide the guideline in terms of how they prioritize these two types of patients. Hospitals might also reserve beds for their high revenue generating specialty patients. Okay, so when you look at how their capacity or specialty beds are allocated across different specialties, they don't match with demand at all. Okay, for a lot of hospitals, for example, orthopedics patients generate a lot of revenue, and you have huge orthopedics units where cardiology or general medicine units, although demand is very high, you have very limited capacity. And then, of course, policymakers play an important role. So Ben had mentioned outcome-based payment. So this, of course, might distort hospitals and physicians' patient admission and selection decisions. So there are some studies show that we do see once these outcome-based payments are introduced, there's a difference in terms of how hospitals and physicians select their patients. And finally, patient outcomes unfold over time, right? Even if we are able to take into account, for example, we look at readmission rate in 30 days or in 90 days, there are things that unfold in much longer period of time. And how to think about measuring these outcomes is a very important question here. So all these different parties are involved in the allocation decisions, and I want to kind of show you two examples, empirical examples about the behavioral factors on the physician side. So these are papers that of my own that I've looked into the data here. So in the first example, I want to talk about a very, very simple scenario. So we're looking at the hospitals that are vertically integrated. So these are 24 Kaiser hospitals in Northern California. Because they're vertically integrated, so there are less incentive issues that physicians are facing. Their physicians are paid by salary. And another simplification in this setting is that there's one physician that makes ICU admission decisions for ED patients. And these hospitals also prioritize surgical ICU admissions to medical admissions. But you'll very soon realize, well, there's kind of intertemporal externality here, right? If the ICUs are operating at close to full capacity, if I'm admitting a patient at time T, this means I'm taking a bed away from patients that arrive at T period time T minus one, T plus one. So the question is, are physicians forward-looking here? That seems to be the reasonable thing to do. It's a dynamic problem, but the answer is not really, okay? So what we did in this paper is we estimated physicians' potentially dynamic ICU admission using data over 2 years from these 24 hospitals. For those of you who are familiar with the empirical IO literature, this is just a RUS model, but we're going to also estimate the discount factor in this model. So what we find is that the average discount factor is about 0.3. Okay, so what this means is that physicians not even taking into account very much what happens in 2 hours. Okay, so they are not on average forward-looking at all. Okay, when we look at the kind of hospital by hospital, we find that this discount factor also varies significantly across hospitals. So some hospitals, physicians are very forward-looking. The discount factor estimated is about 0.9, and some are, not forward-looking at all. Okay, essentially making static decisions here. So what we learned here is that, within the same hospital system, there's a huge heterogeneity in physicians' forward-looking behavior. Okay, and this is not an isolated example. So there are also similar findings in other diagnostic settings that people have looked at. There's a huge behavioral heterogeneity across physicians. Okay, so here we also look at, how big is really this impact? Is this behavioral aspect really important? So for some hospitals, we find that, more forward-looking can be equivalent to adding essentially 1 ICU bed or saving over $1 million operating costs per year, okay, which is significant. So the point I want to make here is that, taking into account the physician behavior or sometimes, naive decision-making is really important in thinking about, coming up with a good mechanism for allocating these hospital resources. Okay, so some kind of interesting questions here to think about is, for example, if we provided physician with more accurate information, are they going to be able to make better decisions? So a lot of hospitals use real-time census information where you can really see who exactly are the patient at each unit, at each stage of their treatment. Sometimes these information is not available to physician. So there's a kind of information design type of question here. Also providing, demand forecasting tools. A lot of hospitals are kind of quickly adopting these tools to try to help their physician to make more informed decisions. Hospitals also, of course, provide guidelines and incentives to want to try to reduce the heterogeneity in physicians' behavior. How could we do that in order to improve efficiency in these important resource allocation decisions is another question. And also, Ben had mentioned this too, the role of AI in improving allocation decisions. Hospitals are also kind of jumping on some of these tools to help them reduce heterogeneity, behavioral factors. In terms of on the hospital side, so those are, the physicians, hospitals, allocation of shared resources. That's a big question across different departments. So medical versus surgical patients, for example. So here, really, the incentives and behaviors of all parties matter. And so going back to some of the points that Ben had mentioned, I think market design tools which are robust to physician behavior and error, that we try to take those into account is really important, and also a huge opportunity for future research. In the remaining 2-3 minutes, I'll mention another kind of a quick example. So in this setting, we looked at cardiac surgery scheduling at the Columbia Hospital. There is quite a bit of work done in the operations community on surgery scheduling, but I think there's still huge room for future research, especially when you start looking at data, looking into what's actually happening in practice. So here, like many hospitals, the OR schedule is organized by blocks. So one room is assigned to one surgeon for an entire day. It's partially kind of a result of surgeons preferring block schedules so that they can, spend other days teaching and seeing patients. And the schedule is also fixed months in advance. So a result of that is that, when an urgent case arrives, the surgeon who has the OR block is more likely to perform the surgery. But what we find is that adding one more case to surgeons' daily workload actually increases the OR time on average substantially by close to 30 minutes, and post-surgery ICU time by over 20% on average. So huge impact. So this shows that inefficient allocation of OR leads to surgeon fatigue and poor patient outcomes. So again, kind of highlighting how taking into account the physician behavior is going to be very important in thinking about the good mechanisms. So just kind of very quickly, the kind of questions that I think are worth thinking about is, can we think about mechanism to incentivize surgeons not in schedule to share workload, a more accurate forecast of OR time by surgeon? But here, of course, there's also incentive issues because the surgeon knows the best about their patient, and they may not kind of give, they may have incentives to, overestimate or underestimate the OR time. And then from the cardiac surgical department perspective, they're also important to play an important role here, how they're prioritizing between elective and urgent cases. incorporating scheduling considerations when we're matching cases to surgeons, right? And also coordination of scheduling of specialists and staff, your supporting team in the surgery is also important. And better allocation of pre-surgery beds and post-surgery beds. So this is an important thing for hospitals to decide. So finally, incentives and behaviors of all parties involved play key role in efficient OR allocation, and also other important resource allocations in hospitals.